Assalamualaikum warahmatullahi ta'ala wabarakatuh. Allahumma salli ala Sayyidina Muhammad wa ala alihi wa sahbihi wa baraka wa sallam. Hello and a very good morning to everyone. My name is Dr. Ayub Afandi from Radiology Department Miri Hospital. Thank you for inviting me and I am glad you can join us today. I am very excited about today's topic. Our topic today is intracranial pathology, cerebrovascular accident and intracranial bleed or hemorrhage or hematoma, ICB. So, did you know these two intracranial pathologies are some of our major hospital admission and therefore a wake-up call for us to have an understanding to recognize imaging features to help us managing our patient. So this is my target audience. Before that, this presentation, the examples, the cases and pictures are for educational purpose. My target audience for our discussion today is generally to our fellow housemen and junior medical officers. This is the outline of my presentation. Before I go to discuss about the intracranial pathology, I would like to talk briefly about the CT scan. Then I would go through some basic intracranial anatomy and then to the main intracranial pathologies to be discussed, which are the cerebrovascular accident and intracranial bleed. And for ICB, we will look into the following different types of ICB. So this is the one and only one CT machine serving the Miri community. On the top left is gantry, which houses the rotating X-ray machine as well as the table. On the top right is the computer console, which our radiographer remotely manage the CT machine. What is CT? Or some people say CAT scan. CT means computerized tomography or computerized axial tomography. Tomography comes from Greek words tomos, which means slice or section, and grapho, to write or to describe. It is a type of imaging modality which uses computers and rotating X-ray machine to create cross-sectional image of body. How it works? The X-ray machine within the gantry will start to rotate while the table will slowly moves you into the scanner. And so this is a basic structure of a spiral CT. In spiral CT, fourth generation CT machine, the X-ray tube rotates continuously in one direction while the table which patient is lying is mechanically moved through the X-ray beam. So the data is acquired as a continuous volume of contiguous slices. Thus, it reduces the possibility of artifact and it is much more faster. So in our CT machine is a fourth generation type of CT machine. We have third, second and first generation. So the data acquired from the CT scan is then computed and scaled to a numerical value or Hounsfield unit. So each number or each HU represent a shade of grey. Our human eye can differentiate 30 shades of grey compared to the modern CT, which can differentiate until more than 2000 CT number of HU unit. So this scale represent the different shades of grey we see from CT. It is assigned water as 0 HU. Then we have the very dark end represent very low HU such as air. And extreme right represent the brightest scale with Hounsfield unit more than 1000. Then in between we have fat, simple fluid, soft tissue, acute blood and others. Next, the CT image grayscale component. We can manipulate it via the CT number to facilitate assessment of different structure. We call it windowing. So for example, this is the bone window, highlighting the bone and the bullet. Next is brain soft tissue windowing, highlighting the soft tissue edema. And next is the lung window, highlighting the lung tissue. So we also need to know there is artifact in CT imaging. So artifact is an appearance or features that is seen on an image which does not actually exist. It is common. It is also occur in all modalities. For example, in X-ray, CT scan, ultrasound, and MRI. So it can it cause it of course it can mimic pathology, and it occur for various reasons. It can degrade the image quality to non-diagnostic level, and it can mislead our diagnosis. For example, we have patient-based artifact, motion artifact, or artifact from the patient's clothing. We have a physics-based artifact, for example, beam hardening artifact. And lastly, we have a hardware-based, for example, ring artifact. So here is an example of beam hardening artifact. We have the band of low attenuation across the points. This reduces tissue differentiation and is characteristic of beam hardening artifact. Next, we have dentures causing artifact. Next, we have a motion artifact, characteristic movement blurring. And finally, metallic artifact. There is a gross star-shaped metallic streak due to the gunshot pellet. So for CT brain, we can perform a non-contrast, contrast-enhanced study or CECT, CT angiogram or CTA, and CT venogram, CTV. They are differ in the timing of the scan and technique of the scan. Here is an example of a non-contrast study. One of the clues is that the vessels are not enhanced. Next is an example of contrast enhanced study as evidenced by contrast enhancement of the vessel. Next is an example of CTA for evaluation of circle of Willis. In general, workup start with a non-contrast brain, and then we progress to contrast enhanced CT or MRI when necessary. These are some indication for non-enhanced CT brain. For example, we might have patient complain of having symptom of cerebral vascular disease. For example, in case of stroke, venous sinus thrombosis, patient having altered mental status. So we need to rule out intracranial bleed, tumor, infection, infarct, hypertensive emergency, or in case of suspected increased intracranial pressure or acute delirium case, patient post-trauma case, head trauma, or case of child abuse, suspicious for child abuse, a case of patient complaining of worse headache in his or her life, or a case of headache in patient with underlying cancer, headache developed after head trauma, or pregnant patient with headache. And then we have case symptom of seizure, but there is a change in symptom or seizure pattern. And finally, surgery related, for example, for pre or post-op evaluation, or a case of shunt malfunction. So contrast enhanced CT brain, it is indicated to look for a space occupying lesion and infection. Here, we have an example of right frontoparietal hyperdense intraaxial lesion that enhance in post-contrast study. Small surrounding vasogenic edema, and also but no significant mass effect, no midline shift. Here is an example of metastatic malignant melanoma. Next, we have a finding hypodense lesion, but it is ill-defined. So with help of contrast, we have a ring enhancement which suggestive of brain abscess. So next, CT venogram. It's where we would like to visualize the anatomy and patency of cerebral veins. For example, in case of cerebral venous thrombosis, or in case of for pre-operative assessment, which involve the posterior cranial fossa or a transverse sinus vein. And its venous thrombosis, for example, cerebral venous thrombosis has a non-specific presentation. So usually we proceed with a non-enhanced CT brain and there is a possibility of venous thrombosis when we see a direct sign of thrombosis, hyperdense sign, or infarction in a non-arterial location. For example, if it's occur in a parasagittal or bithalamic, or if it's hemorrhagic, cortical or lobar hemorrhage, or if there is a finding of cortical edema. So if a patient with a local infection, it might have a complication that leads to cerebrovenous thrombosis, for example, in case of mastocytitis, sinusitis, or a coagulopathy condition, or there is a risk factor to develop cerebrovenous thrombosis, for example, patient taking oral contraceptive or a pregnant patient. Here are example of a normal CT venogram. This one is axial cut, which visualize the transverse sinus. Here is sagittal view. Visualize the superior sagittal sinus. Here is the inferior sagittal sinus, straight sinus. So for positive finding that indicate there is a possibility of cerebral venous thrombosis. Here we have a hyperdense straight sinus or cot sinus, and next is the straight sinus, cot sign. If we have a vasogenic edema or lobar hemorrhage that occur at a non-arterial territories, so this is indicated for CT venogram. So upon doing the CT venogram, if there is a positive finding of empty delta sign or a non-opacification of sinus or filling defect, so this is strongly suggest for cerebral venous thrombosis. So next, CT angiogram. CT angiogram, we would like to detect or confirm the abnormalities within the blood vessel in brain. For example, in case of ischemic stroke, to detect the occlusion and thrombosis of artery. In case of subarachnoid hemorrhage, to look for aneurysm, and to assess for presence of vascular malformation or ongoing bleeding. So CTA, it will opacify the intracranial arteries. Here is an example, non-contrast enhanced and contrast enhanced CT brain showing an irregular area of mixed density with a small focus of hyperdensity in the right parietal region and adjacent to the body of right lateral ventricle. It shows serpiginous enhancement with early venous filling of the straight sinus. Here is the axial and parasagittal view of CT angiogram, showing that the distal branch of the right middle cerebral artery is involved in arteriovenous malformation. Early venous filling of the deep cerebral venous system and the straight sinus is demonstrated. So, blood taking done, and before that we have taken the history. So we had reviewed the blood parameter. We have performed the physical examination. So we might have some diagnosis in mind with its differential. Now it's time for next investigation, which is imaging. So now our patient is indicated for further investigation with CT imaging. So we had judged the benefit versus risk. Patient had been stabilized. So imaging might be beneficial for the patient well-being. And in case of pregnant lady, the risk of radiation to fetus need to be thoroughly explained to the patient and her husband, and consent must be taken from them. Relatively high radiation dose involved, so it is important to avoid scanning pregnant lady, particularly in first trimester. So in case of patient requiring sedation, for example, a non-cooperative patient or children, so sedation might be helpful to facilitate the imaging. So if patient wearing some jewelry piercing, so he or she need to remove the piercing or jewelry, and it's better to patient to change to patient gown. Patient need to be able to lie flat, cooperative, and for additional point, patient need to be able to hold breath at least 10 seconds in case for CT thorax. For contrast study, patient need to be fast about 4 to 6 hours prior imaging. A normal creatinine and eGFR is a must, so nephrologist input will be helpful in case of derange in renal profile or eGFR. So please make sure patient have adequate IV access. For example, for a CCT, we might prefer pink granula, and CT angiogram, we prefer for green granula 18 gauge at the antecubital fossa when performing the CTA imaging. This will facilitate us for better image. And beware, careful with patient having history of anaphylactoid reaction or allergic or asthmatic. Contrast might aggravate their condition, so therefore they need to be covered with prednisolone or at least IV hydrocot prior to the CT. Okay, so now patient is now safely transferred back to us from radiology department after CT. Now let's have a look at basic anatomy of brain before we review the CT imaging. So first, this is an axial cut CT brain near the vertex or through the superior frontoparietal region. So to differentiate between frontal lobe from parietal lobe, we look of an inverted omega sign. This sign corresponds to the central sulcus. So frontal lobe is anterior to the central sulcus, while parietal lobe is posterior to it. And this is the precentral gyrus, and this is the postcentral gyrus. Now this is an axial cut through the lateral ventricle. Here we would like to visualize the parieto-occipital sulcus, which separate the parietal lobe from the occipital lobe, and it is best appreciated in sagittal plane. Y sign. We need to find the Y sign. So next, this is an axial cut through the basal ganglia. So we can visualize the sylvian fissure or lateral fissure, which separate the frontal lobe from the temporal lobe. At this level, some deep gray matter structures can also be visualized. So this is the head of caudate, lentiform nucleus. This is the thalamus, insular cortex, and in the midline we have a lateral ventricle and third ventricle. So next, axial cut through the midbrain. This is the midbrain. Posterior to it is basal cistern. Here we can see the temporal horn of right lateral ventricle. Normally we couldn't see, or at least it appears as a slit-like. If it becomes more prominent, this might be a clue that this patient is having an early hydrocephalus. This is next axial cut through the pontine level. We can appreciate the pons in the midline with fourth ventricle posterior to it. So this is axial cut through the medullary level. We can see this is the medulla. And finally, axial cut through the foramen magnum. So now we take a look at the ventricle, which are part of the CSF spaces. So ventricles, we have lateral, we have two lateral, right and left, third, fourth ventricle, and which they communicate with the subarachnoid spaces. So here, this is the lateral ventricle, right and left. We have an anterior horn and posterior horn of lateral ventricle. Here, this is a lateral ventricle anterior horn and the posterior horn. So here for revision, this is the caudate area, caudate. This is the thalamus, and much lower cut. This is the third ventricle with a quadrigeminal cistern posterior to it. So next, this is the temporal horn of the lateral ventricle, midbrain, and fourth ventricle. So this is an example of hydrocephalus. A is a normal CT, non-enhanced CT brain. We couldn't see or appreciate the temporal horn of the lateral ventricle. So here it's become more prominent, and C it become much more prominent. So this indicate this is an example of a hydrocephalus case. So next, CSF space. There are also many cisterns intracranially as a part of the subarachnoid spaces. For example, here we have premedullary cistern in front of the medulla, prepontine cistern, suprasellar cistern, interpeduncular cistern, ambient cistern, and quadrigeminal cistern. So before we start reviewing in a CT brain, first we make sure it belongs to the correct patient. Then we check if it is a non-enhanced or enhanced CT study. So there is a mnemonic to help review the CT brain in a systematic way, ABBCS, which I will go through a minute later. And don't forget to use the bone window to look at bones. Here we need to have an extend search pattern. It involves the temporal lobe, inferofrontal lobe, orbits, sinuses, ear, scalp, and oropharynx. This area we might miss during a normal review CT image. So here, this is a CT scan bone window showing a temporal bone fracture. And this is a case of metastatic melanoma. Patient present with a short history of left-sided proptosis. So here we have a lesion, intraorbital lesion, which is the mets from the primary melanoma. So for ABBCS mnemonic, A for asymmetry, B for blood, C for CSF spaces, cistern, sulci, and ventricle, and S skull and scalp for soft tissue injury. For the asymmetry, first we need to make sure this CT, is it symmetry or asymmetry? Symmetry means everything is in order, in the midline. There is no midline shift. The lateral ventricle is at the center. So here we have two example. Subacute subdural hematoma. We have isodense crescenteric isodense lesion, which cause a midline shift and effacement of the lateral ventricle. It isodense to the gray matter of the brain. So next is an example of acute right MCA infarct, massive right MCA infarct, causing a midline shift to the left. So when we have asymmetry CT brain, we need to look the cause for the cause of the asymmetry. So next is blood. Here is an example of subarachnoid hemorrhage. There is a diffuse hyperdensity in the subarachnoid space, and also it involves the sulci, and there is extension of the bleed into the lateral ventricle. Next is B, brain lesion. Here we have an example of a well-defined smooth extra-axial hypodensity, CSF density. This is an example of frontotemporal arachnoid cyst. So next, C for CSF spaces. Here we have an example of hydrocephalus, dilated lateral third and fourth ventricle. Here we have a subarachnoid hemorrhage involving the cistern, ambient, and the suprasellar cistern. And next, this is an example of effacement of sulci. Here we have a case of a tumor with a perilesional edema causing effacement of the adjacent sulci compared um, to the right side. So we couldn't appreciate the sulci. And next, case of trauma. Here we have a acute bleed that cause a mass effect to the brain. We have an effaced ventricle, enlarged contralateral ventricle, a shift of the brain to the right side, and this is the sulci effacement. We can appreciate the sulci. So next is S, skull or scalp, soft tissue. So um, we need to find any skull fracture or lesion, and then scalp, for example, scalp hematoma or foreign body. So here, this is an example of trauma cases. Patient sustained a coup contra coup injury. We have soft tissue injury and a depressed fracture of right occipital bone in this bone window, and in contralateral it is there is a subdural hematoma. And then another example, case of occipital osteolytic metastatic lesion. Here, bone window depicting the discontinuity of the two occipital plate, and B, soft tissue window showing intracranial mass compressing on the brain parenchyma. Here is an example of left frontal lobe cerebral contusion with scalp hematoma. And next is a bone window showing there is a subcutaneous foreign body. And finally, paranasal sinus. This is a bone window image showing a normal paranasal sinus in coronal and axial cut. Image A is a coronal cut. Visualize the maxillary sinus, infero and middle turbinate ethmoid sinus, crista galli and orbit, and also anterior cranial fossa. And next is D, axial cut, visualize the frontal sinus. And next E, it visualize the ethmoid and sphenoid sinus. Okay, now we have moved on to the arterial vascular territories. So different arteries supply different parts of the brain. We call that as arterial vascular territory. So two pair of arteries supply blood to the brain, okay, which is the carotid and vertebral arteries. So carotid arteries supply 80% of the brain, while vertebral arteries, which join to form the basilar artery, supply the remaining 20% of brain, primarily to the posterior fossa. So we have anterior circulation and posterior circulation. The anterior circulation of the cerebrum consists of largely anterior and middle cerebral artery, while the posterior cerebral arteries are important in the brain posterior circulation. So cross flow between this anterior and posterior circulation occur at the communicating arteries in the circle of Willis. So here are some diagram of the brain at different level divided by different vascular territories. In this image, arranged accordingly from below to upward. This is the superior cerebral artery, posterior inferior cerebral artery, and here MCA, it covers the lateral side of the brain up until the vertex. At the middle, we have ACA, and next we have PCA, posterior cerebral artery. So when we say vascular artery, we have a watershed area where there is a territory that have a risk of hypoperfusion. This is a border zone between the major cerebral artery, in between the major cerebral artery. So here we have a cortical border zone in between the ACA and MCA. Next is internal border zone. It lies between the LCA and the MCA. And next is the cortical border zone between the MCA and PCA. So here, this is an example of watershed infarct at the border zones between the major cerebral arteries. So, cerebrovascular accident, or we call it stroke, it is an acute loss of neurologic function. It is a leading cause of chronic disability, dementia, and cause of death. Malaysian patients with stroke are approximately 10 years younger than patients in the developed countries. So for stroke, it is a clinical diagnosis. We have two types of stroke. Ischemic stroke, about two-third of cases is ischemic stroke, while one-third is hemorrhagic stroke. So patient might have a symptom we can call as a BFAS. There is a balance difficulties, eyesight changes, facial weakness, arm weakness, and speech difficulties. So here, ischemic stroke, it is the most common type of strokes. It is caused by severely reduced blood flow caused by the blocking or narrowing of the blood vessel, or it might be secondary to thrombotic or embolic disease. So the symptoms depends on the circulation affected. So patient, for example, patient having vertigo, ataxia, diplopia, dysarthria, bilateral limb sign, the posterior circulation might be involved. So we have a patient with a risk factor, for example, patient hypertensive patient, smoker, diabetic, hyperlipidemia, atherosclerotic, patient having atrial fibrillation, patient have a carotid stenosis, patient taking oral contraceptive, or obese patient. This kind of patient might have a risk for ischemic stroke. So here, let's identify the abnormal hyperdensity on these two scans from two different patients. The image on the left shows a serpentine hyperdensity outside of the brain in the Sylvian fissure. So what lives in the Sylvian fissure? Okay, it's a middle cerebral artery. So the image on the right also shows a hyperdensity, but this time it's between the cerebral peduncle in the interpeduncular system. So this is the top of the basilar artery. So this is a finding of acutely clotted blood which looks hyperdense or bright on CT. So this is the dense artery sign represent acute clot. So we proceed with CT angiogram. Here CT angiogram highlighting the arterial vessel. It demonstrates right MCA occlusion. This is the axial cut. There is an interruption of the right MCA. And here is the coronal cut demonstrating the right MCA occlusion. So for acute stroke, ischemic stroke, we have a window of 12 to 24 hours. In the CT, not enhanced CT, there might be a loss of gray or white matter differentiation or sulcal pattern due to the edema, loss of insular ribbon sign, and 1 to 7 days there is a hypodensity changes in the vascular territory distribution due to the cytotoxic edema. Mass effect hemorrhagic transformation may occur after 2 to 4 days. So this is an example of early left MCA territory infarct. There is a subtle effacement compared to the contralateral side. Here we have the south side, here no. There is a subtle effacement of the gray-white matter differentiation due to edema and the insular ribbon sign. There is a loss of insular cortex differentiation, gray-white differentiation. Here there is a large area of hypodensity within this top image. And here there is a this is the MCA vascular territories hypodensity due to the cytotoxic edema. So next, Hemorrhagic transformation is seen in 50% of cases. Usually happen is seen in the first 4 days, rarely in the first 6 hours. So here we have a dense MCA segment thromboembolic material. There is a hyperdense sign with abrupt cutoff on the CT angiogram with comparatively mild reduced MCA branch filling. So subtle hypodense blurry at the right insular region. So after a few days, patient deteriorate, and after this is this repeated not enhanced CT showing there is a large acute intraparenchymal hemorrhage. So next, for subacute or chronic timing, more than 1 week, 2 months. So we have a better lesion delineation from the hypodense lesion. We have better differentiation, well-defined low attenuation lesion. There is a decreased mass effect, ex vacuo dilatation of the ventricle. The ventricle become much more prominent, and there is a loss of parenchymal mass with the sulci of ventricular widening due to the encephalomalacia. Here is an example. Chronic right MCA territory infarct. The area demonstrates CSF density due to loss of brain substance secondary to encephalomalacia, which means CSF filled the dead space left following the infarct. As a result, there is a widening of local sulcal space and ex vacuo dilatation of the adjacent ventricle. In this case, the cerebral fissure and the right occipital horn. So when we discuss about the ischemic stroke, we need to know the aspect score, Alberta Stroke Program Early CT score. This is a score, segmental estimation of the middle cerebral artery vascular territory is made, and 1 point is deducted from the initial score of 10 for every region involved. So here, for example, we have caudate nucleus, putamen, internal capsule, insular cortex, M1 region. The anterior MCA cortex correspond to the frontolateral region. M2 correspond to the anterior temporal lobe, and M3 correspond to the posterior temporal lobe. And then we have M4, M5, and M6, which immediately superior to the M1 area, M5 immediately superior to the M2, and M6 immediately superior to the M3. Okay, so we have 10 area. One area affected by the infarct, ischemic infarct. So we will deduct 1 point. So here at the basal ganglia level, not enhanced CT brain. Here is the caudate internal capsule, lentiform nucleus, insular cortex, M1, M2, M3 area, and next coronary data level, a bit high axial cut. We have M4, M5, and M6. And for your information, we also have posterior circulation aspect score. As is the case of anterior circulation, posterior circulation also we have a 10-point scale where points are lost for each region affected. So what is the difference is the pons and the midbrain are worth 2 points each. So regardless of whether they are affected bilaterally or unilaterally. So thalamic 1 point each, thalamus 1 point each, occipital lobes 1 point each, midbrain 2 points, pons 2 points, and cerebellar hemisphere 1 point. Okay, next, hemorrhagic stroke. There is a compression of surrounding brain tissue secondary to accumulation of blood from ruptured weak vessel. There are two types of hemorrhagic stroke, which are intraparenchymal hemorrhage and subarachnoid hemorrhage. So that brought us to the next topic, which is intracranial bleed, ICB. So intracranial hemorrhage or intracranial bleed, ICB, we can differentiate to intraaxial, parenchymal bleed, or extraaxial, outside the brain parenchyma. So we have intraparenchymal hemorrhage. Next, under the extraaxial, we have intraventricular hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, and extradural hemorrhage. The extradural hemorrhage, the extraaxial, it differentiates according to the location of the bleed. So, number one, intraaxial is the intraparenchymal hemorrhage. We have primary and secondary hemorrhage. Primary, it might be due to the lobar hemorrhage, secondary to the cerebral amyloid angiopathy, or hypertensive hemorrhage, which involve the deep white matter. We have a common area for hypertensive hemorrhage, for example, basal ganglia, thalamus, pons, and cerebellum. Intraparenchymal hemorrhage, we have it may be secondary to vascular malformation, secondary to cerebral venous thrombosis, or tumor. So CT features is according to the age of the hemorrhage. We have acute, so it will be manifest as hyperdense, and subsequently it might be isodense and finally hypodense. We have a loss of gray or white matter differentiation due to the edema, okay, and we might have a mass effect which cause loss of sulci pattern. There is a ventricular effacement, midline shift, basal cistern effacement, and herniation. And according to the site and size, it will affect the management. So here, this is an example. The first three images show a large hematoma in the right basal ganglia with a massive edema. So subsequent follow-up after 1 year, it shows linear cavitation due to the tissue loss and hypodensity of the basal ganglia as a result of gliosis. And here it is an example of left frontal intraparenchymal contusion and a follow-up of a non-enhanced CT brain post 15 days trauma was done. It shows an area of hypodensity. Oh, also noted, this is the scalp hematoma. Okay, this is a case of 82-year-old male hypertensive smoker presented with a severe headache and right side hemiparesis. The initial CT brain was done here. It revealed an intracerebral hemorrhage at the left basal ganglia, and then abruptly patient deteriorated and went into coma approximately 3 hours after the first CT. So second CT was done. There is a large increase in size of the initial hemorrhage with extension to the ventricular system. So for take-home message, about 25% of ICB expansion can occur within the 24 hours after hospitalization. Okay, next we have a case of intracerebral hemorrhage. And then this, we proceed with CT angiogram. We noted a spot sign which indicate there is an active bleed. So this patient have a susceptibility to have a the lesion might be more extensive after a few periods of time. Okay, next, number 2, under the extraaxial hemorrhage, we have intraventricular hemorrhage. We have two types, primary, about 30% of case, and secondary, about 70% of case. Primary, the lesion, the bleed is confined to the ventricular system. It might be caused by hypertension, vascular malformation, secondary to anticoagulant therapy, or a tumor, especially involving the choroid plexus. For secondary intraventricular hemorrhage, there is expansion from the pre-existing intraparenchyma or subarachnoid hemorrhage into the intraventricular hemorrhage. For example, in case of hypertensive hemorrhage, lobar hemorrhage, subarachnoid, and trauma. So for the rest of the extraaxial hemorrhage, these three, subdural, extradural, subarachnoid, it is different in their location of bleed. So here, extraaxial anatomy, this is the pia mater, this is the arachnoid space, subdural space, and dura mater. In subarachnoid hemorrhage, the bleed is within the subarachnoid spaces. In subdural hemorrhage, it might be cause of venous hemorrhage, which cause an artificial subdural space between the arachnoid mater and dura mater. And EDH, extradura hemorrhage, is a collection of blood that forms between the inner surface of skull and the outer layer of the dura. Okay, number 3, subarachnoid hemorrhage, blood within the CSF spaces between the arachnoid mater and pia mater in the basal cistern, sylvian fissure, and the sulci. So, clinically, patient might complain of severe headache. There is a meningeal sign. Patient might have lethargy, nausea, vomiting. So, if you notice, it's not totally specific symptom, but the cause might be suggestive. For example, subarachnoid hemorrhage after a head trauma, patient might have it might be caused by saccular or berry aneurysm or might be due to vascular malformation. So complication from the arachnoid hemorrhage, patient might have rebleeding in within the 24 to 48 hours. Patient might develop hydrocephalus after 24 hours, and patient might have a vasospasm after 7 to 10 days. So this is an example of the of this circle of wheels. So here we have an example of subarachnoid hemorrhage involving the basal cistern and also extend to the sulci. Here B and D and the sylvian fissure, and also there is an extension into the lateral ventricle. Okay, here we have a case 72-year-old woman, hypertensive, complaining of worsening headache over the previous 2 weeks, but no focal neurological deficit. So in the non-enhanced CT brain, there is a hyperdense, well-defined lesion. Because of the location, it's suspicious for aneurysm, and the CTA angiogram confirm the finding. Here is an example of subarachnoid hemorrhage and berry aneurysm. There is a 5-pointed star pattern, subarachnoid hemorrhage. So the source of bleeding, majority of the blood appear to be located anteriorly. And after the CT angiogram, we did the reconstructed CT angiogram. It showed anterior communicating artery aneurysm, this one. So this is an example of arteriovenous malformation. 65-year-old man complaining of acute onset of headache. Non-contrast study show bilateral subarachnoid hemorrhage and a parenchymal hemorrhage. Okay, so proceed with CTA. CTA show location of the parenchymal hemorrhage, a flow-related aneurysm at the anterior communicating artery, which considered as the cause of the subarachnoid hemorrhage. But here, from the CTA also, we can see there is a features of arteriovenous malformation with a nidus in the left frontal lobe. So we have 2 lesions, intraparenchymal hemorrhage, subarachnoid hemorrhage, and also arteriovenous malformation, and also aneurysm. So next, number 4, subdural hemorrhage, a collection of blood within the dura and arachnoid matter. Clinically, patient might complain of severe depressed consciousness with a papillary abnormality. It might be due to head trauma, or in case of non-accidental injury in infant, fall, especially in elderly, or patient with underlying bleeding disorder. For example, patient taking anticoagulant warfarin, so patient might have risk for subdural hemorrhage. So for subdural hemorrhage, it has a particular shape, crescenteric or banana in shape. It might be due to bridging cortical dura venous torn or venous in origin. It might be the site of contracoup, and it can cross sutures. So for the timing of the subdural hemorrhage, acutely, it might represent as hyperdense crescent in shape. There is an active bleed if there is a central hypodensity, or patient is the density might be variable in coagulopathic patient, for example, patient taking warfarin. And then for subacute, 7 to 12 days, the blood is broken down. So we can see here, now the bleed is isodense to the gray matter, so it's difficult to see. One of the way we can recognize there is subdural hemorrhage, like for example here we can see there is shift of the midline shift. So we can guess there is something pushing the cerebral. There is a midline shift, so asymmetry is important to be recognized first. And then here, chronic hematoma approaches CSF density, so we have a hypodensity crescenteric lesion, so it indicates this is a chronic subdural hemorrhage. Okay, this is a unique case. We have two density, hypodense and hyperdense. It indicates this is the chronic subdural hemorrhage, while this is the acute bleed. And next, extradural hemorrhage, blood collection between the inner table of skull and outer layer of dura. Patient might have a lucid interval and gradually reduce consciousness. Patient also may complain of severe headache, and it might be secondary to head trauma, and usually there are skull fracture underlying the extradural hemorrhage, so we need to see further for skull fracture, and it is usually arterial in origin. So extradural hemorrhage, it shaped like a lens shape. It can extend but not crossing the suture, lentiform in shape. So here an example of left frontal extradural hemorrhage with adjacent skull fracture in this bone window. It's much more clearer. The hematoma is classically lentiform in shape. So this is an example of extradural hemorrhage. It is a lens or biconvex in shape. Here we can see there is a midline shift, mass effect due to the hemorrhage and the edema. So now this is the hemorrhage. So now this is a brief summary for extradural and subdural hemorrhage. So they differ in their location. Usually for the extradural, it involves the artery. It is the site of the coup in case of trauma. In subdural, it is the site of contracoup, and it is secondary to bridging vein torn. Its symptom might be due to patient might complain of lucid interval followed by unconsciousness, while in the subdural, patient will gradually increasing headache and confusion. So for the CT appearance, the difference is extradural. The lesion, the bleeding might expand medially. It may cross midline above the falx, but it cannot cross the suture, and it is usually associated with skull fracture. Compared to the subdural, it constrained limited by falx. It cannot cross midline, but it can cross suture, and the shape is different. Here is a lentiform in shape. This subdural, banana or crescentary in shape. So finally, I have come to the end of my presentation. So in summary, we have looked at different type of CT brain studies. We have non-enhanced, contrast-enhanced, CTA, CTV, depending on the indication. We have looked at the basic reading approach of CT brain. We briefly reviewed the basic anatomy, and then we have discussed about the CT features of each CT, depending on the timing of patient presentation, and also we have also gone through the different type of the intra-axial and extra-axial hemorrhage. So finally, this is my reference for my presentation, and thank you very much for your attention. If you have any question or query, you can email to us radiology.hmiri2@gmail.com. Thank you so much.